Hi, I'm back. Okay, part two of pain theories. Now we're going to talk about the mechanisms of pain reception. How do we feel pain? What allows us to feel that pain? So first we have the nociceptors, which we were talking about. Those are those peripheral nerve endings present in almost all types of tissues that we have. Your bones, your soft tissue, your ligaments, almost everything has peripheral nerve endings that will have that reception of pain. They respond to noxious stimuli. That would be like a thermal heat response or stimuli, a mechanical response, and a chemical stimuli. You get the release of substance P, prostaglandins, and leukotrienes. A transduction where it converts that initial stimuli into an electrical activity, which you guys all know as an action potential. Those action potentials propagate or they move along the afferent nerves to the spinal cord where that pain is thus received. So thank goodness we have a diagram because that's a lot to digest. So here you have that injury. Here's that famous brick that we have to keep hurting us. It comes down into that tissue, releases these chemicals that we talked about. And really not that important for you to know exactly what these chemicals are called. Prostaglandins are very common in the leukotrienes. So just to kind of have an idea of what those are, you can see where they synapse here and they come up and that substance P releases into these different areas. You get the histamine response. It goes to that dorsal root ganglion because this is an afferent nerve. And it goes right in there into the spinal cord to where it's going to say, ouch, that hurt. So you have these different sensations. Cutaneous, we know that's our skin, right? It's well localized. It's sharp, it's prickling, and it's tingling. And if you've already read chapter 4, this is a chance for you to kind of quiz yourself and say, okay, which one of those fibers is it that this resembles? Is it a myelinated or an unmyelinated? Is it my A delta? Is it my C fiber? If you haven't read it, this is a good time to go get that chapter out and start looking at that stuff because that will be things that you'll want to know for our first exam. Then you have musculoskeletal, which is a more poorly localized, dull, heavy, or aching type of pain. And then our visceral refers more superficially, and so that's sometimes, even though it's achy like the musculoskeletal, it will have that superficial referral versus the deep referral. So that's how you can sometimes differentiate between a person who's got an injury to their musculoskeletal tissue versus the visceral, versus somebody who just has an injury to like a superficial cutaneous area. So here's where we get into the meat of things, and this is a little confusing at first, but hopefully you guys have had some exposure to this in your classes last semester. This is the mechanisms of that pain transmission. We have different fibers. These are our afferent nerve fibers. So one of them that's very infamous that you'll get to know quite well is what we call your A delta fibers. They're fairly small and they're myelinated, so this allows them to transmit that action potential pretty quickly, pretty rapidly, about 30 meters per second. They respond to that high intensity mechanical stimulation, but they also respond to heat and cold. They cause that sharp stabbing or prickling pain. It's a quick onset, doesn't last very long, so the duration is short. It's very local and there's no emotional involvement with it. So as you can see, when we go back to that cutaneous, it kind of resembles this right here. So when that brick first hits, you're going to get that ouch, but then that part goes away, and then you also are stimulating what we call your C fibers. Those are also small, but they're unmyelinated, and when you have an unmyelinated nerve, it takes it a lot longer to transmit that action potential, and you can see that it's about 1 to 4 meters per second compared to that 30 meters per second for that myelinated A delta fiber. So it's quite a bit slower in getting there. It also responds to that mechanical noxious stimuli and also to thermal, and which would be that heat and cold, and also to chemical stimulations. It can cause that dull, throbbing, aching, or burning pain. it's going to be reported as tingling or tapping. It's a much slower onset. It lasts longer. It's more difficult to handle emotionally, and it's usually not local. It's usually diffused out area. And so you can tell that this is going to be kind of more what we feel in here with that tissue damage. So that being said, what do you think when that brick is falling on your foot? Are you stimulating the A delta fibers, the C fibers, or both? So did you get that answer right? So as you can see, it's actually both, right? You get that high intensity mechanical stimulation of those nociceptors, what causes that sharp pain transmitted by those A delta fibers. So this is where you can quiz yourself. Are those A delta fibers large or small? Are they myelinated or unmyelinated? And are they quick or are they slow? And what kind of sensation do they give? Is it more of that sharp pain or that dull, achy pain? And then you have also the damaged tissue what happens, it releases those chemical mediators that cause inflammation, right? So that's when, okay, that brick really hurts, starts to swell up. You start to get those chemical mediators that cause that acute inflammation, and you get that transmission of those C fibers. And this is where you want to ask yourself, are those C fibers myelinated, unmyelinated, fast, slow? Here you go. And if you get that all right, then you'll be ready for the exam. Nice job. So then, of course, we have one other type of afferent nerve fiber that we need to talk about. So these are your A beta fibers. So beta, these are large. So just think beta large. They're myelinated. So if you think it's large and myelinated, you think it's going to be faster or slower than the other two? You're right. They conduct much more quickly than both the A delta and the C fibers. They're located in our skin, our bones, and our joints. They're usually transmit sensation related to vibration, stretching of skin, and you can think about like when we do a myofascial release or traction, and mechanoreception, but not pain. So these are things that are caused by these nice gentle stretching of your skin from traction or some other thing. But there's always an exception, of course. So during that neuropathic pain or that central sensitization, these neurons alter transduction so that the normal stimuli results in pain. So this we oftentimes find with that chronic pain patient or that patient we talked about with the complex regional pain syndrome. So here's a nice chart from Cameron for you to look at just to kind of put everything in perspective and kind of help you, organize it for yourself while you're studying. So these are your first order afferents. And you have your A beta, and it tells you the diameters versus the A delta versus the C. So you know that the C are the smallest, then the delta, and then the beta are the largest. Then as far as the conduction velocity, you can see that the C fibers are the slowest, and then the delta come next, and then your betas are your fastest. Then it just kind of shows you where things are located. So we know with the unmyelinated, that's both in your muscle and your skin. And the A beta and A delta are more cutaneous, so they're more located in your skin. It's transmitted. It just tells you that the A betas are touch or vibration, whereas the delta is a touch, pressure, and remember it has the temperature and pain. And so remember the A beta is not pain, but the A delta and the C are both stimulated and transmitted by pain. Okay, nice. Okay, so that's the end of part 2. Stay tuned for part 3.